I arrived at the Institute in October of 1961. The Institute had children, I think, from like about age 5 through their teenage years, divided into 2 sections, the girls section and the boys section. And they stayed at the Institute for 11 weeks and then went home for a 2-week vacation. There was no interaction or minimal interaction with the parents at that time.
My introduction to the Institute was by virtue of being invited by Dr. Phelps to start to attend the monthly, I believe they were monthly, steering committee meetings where by each patient's progress was discussed by the physical therapist, the occupational therapist, the hearing and speech therapist, and Dr. Phelps. But then when the Institute relocated to its present location, I started there when it opened in 1967.
It was always a team-centered approach from the time I arrived in 1961. The team grew considerably, though, once we moved to the new location adjacent to Hopkins. I came to the Institute because Dr. Phelps provided a course for therapists that lasted 3 months, and that was a course in cerebral palsy. And that was, at that time, one of the best places to go to learn about cerebral palsy. And that's why I came.
What drew me to the Institute, other than Dr. Phelps's asking me to become involved, was the uniqueness of what we've just discussed, and that is the team approach to the management of each and every patient. Everybody had an equal degree of input into what was expected of each patient, what was expected of each discipline in taking the patients through their day-to-day therapies and what have you. In addition to which, Dr. Phelps was very intimately involved in all of the orthotic or brace fabrication, specific types of braces and for how long they should be worn and what have you. And actually, one of my favorite pictures of Dr. Phelps is with a huge vise sitting on the back of his desk where he would manually take these braces that were made then with steel and bend them to accommodate for the changes in the alignment of the patient's limbs. I think the unique thing about Dr. Phelps, when I would occasionally be summoned to his private office on St. Paul Street, which was where he saw the patients that were not residents at the Institute, was that each and every patient had a folder, their medical record, but he kept each and every birthday card, Christmas card, Easter card, every bit of communication that he had with any patient or their family was incorporated into their charts. And it was just, I think, another indicator as to how attached he became to them and how he was able to perceive the needs of patients and their families. Well, I would think that one of the innovations that came about in the early years of the Institute was the development of equipment and some of the technological advances that allowed children to be a whole lot more mobile than they had been before that. I think the development at the Institute of departments in assistive technology, in communication disorders, I think perhaps one of the more outstanding contributions that Dr. Phelps made was in his early years when he was at Boston Children's Hospital before he became the chairman of orthopedic surgery at Yale, where he and his cohort, Dr. Bronson Crothers, a neurologist, came to the realization that a lot of children with cerebral palsy who were being put into institutions, it was because of their inability to communicate. They had verbal disorders and voice disorders and other communication disorders, and the standardized testing that was done then for IQs and things of that sort was not applicable to those patients because of their inability to communicate. And so that, one of my favorite quotes attributed to him during that period of time was that each and every patient deserved to be fit into the mainstream of humanity and should not be put into any sort of an institution.
I think that he was one of the first people to also do drug trials with children with cerebral palsy. And he would start medication, and the therapist would have to keep exact graphs every day of the things that they were measuring. And he was always very interested in that. And I don't think that had been done anywhere before with cerebral palsy. I think Kennedy Krieger is special because they look at the patient is part of a family, and I think that that's the most important thing about Kennedy Krieger. And one of the things that changed when the Institute moved to the new place, there was still a team, but the parents were a big part of the team, which they had really not been previously. They were encouraged to come into the therapy sessions, into all sessions. They were always welcome, and most of the children, all of the children, were provided with activities to do at home, and with a lot of effort to put them into functional activities that could be done in that child's home, not just an exercise.
When the Institute opened, that was around the time that the field of developmental medicine was being developed. And prior to then, most of the youngsters were under the care of their general pediatrician or family doctor. Or on rare occasions, perhaps they were under the care of a neurologist for seizure disorders or something like that. But with our first medical staff members, such as Dr. Arnold Caputi, who had been trained as a developmental pediatrician up in Connecticut before he came to Baltimore, the patients and their families benefited from pediatricians who just centralized their interest in their field in children with developmental disabilities. And actually the term developmental disabilities probably they began using around that time in the late 60s. Before that, in terms of orthopedic surgeons, there were only maybe 2 orthopedic surgeons in the whole community who had any knowledge of what needed to be done in youngsters who had cerebral palsy related conditions. And there were very few, I can only think of maybe 3, Susan, correct me, but 3 institutions on the entire East Coast. I think there was Boston Children's Hospital, there was the DuPont Institute at that time in Wilmington before it moved to Christiana, and I think there was the Newington Hospital in Connecticut. These were about the only places on the East Coast that specifically directed their practices toward those with developmental disabilities.
In the early 60s, there were a few centers that had concentrated with children with cerebral palsy. And actually I had some training at the Children's Hospital in Boston. And they had a very nice cerebral palsy clinic and a day program, but it was very, very medically oriented. And that was the primary emphasis. It was not such a holistic approach as Kennedy took.
What Kennedy offered that wasn't offered elsewhere was the ability to have specialized clinics, different days of the week, So we would have, for example, our orthopedic cerebral palsy clinic on Thursdays. That clinic would be attended by Susan and her staff and the occupational therapists, and Bob Dennison from the Dennison Brace Shop. It would also include some of the students that were being instructed by Susan, who would come from other institutions on a rotation at Kennedy Krieger for their education in the field of developmental disabilities. And I think that's how word got out into other communities. Once they saw, when they sent their students went back to New England or down to Duke or someplace like that, and they saw what we were doing there, I think that's how the word spread. And our first medical director, when the Institute relocated to East Baltimore, himself had a bit of a physical impairment, and I think that having that, he had the wherewithal to know what it was needed for patients with similar disabilities. And so he was instrumental in recruiting the appropriate people. When I was a resident at the Jefferson Medical College Hospital in Philadelphia, we all spent 1 year of our 4-year residency at the State Hospital for Crippled Children, as it was called then, back in 1961-62. And once a month, Dr. Phelps would drive up from Baltimore, and he would conduct the clinic. I was the first resident in the program to be at Elizabethtown who was from Baltimore. And so we struck up a bit of a friendship. And as a result of that, when I came back to Baltimore to go into practice in the summer of 1964, about 3 months after I returned to Baltimore, I had a call from the medical director at the State Hospital in Elizabethtown asking me if I would be interested in coming up to Elizabethtown with Dr. Phelps for about 6 months to his clinics and then taking over for him. And so once a month from 1965 until 1975, I would go up to Elizabethtown and I would run the cerebral palsy clinics. Having those clinics in 1965, going for a few months with Dr. Phelps, and I would be there and we would discuss the patients, and he would be teaching me and the residents and the physical therapists and occupational therapists from the hospital who were present at that time. And then when I took over, after Dr. Phelps gave it up and turned it all over to me, not only did I have the clinics, but I also would operate with the residents on the children that needed surgery, having learned what particular procedures to do based on my earlier education. In addition to the clinics that I shared with Dr. Phelps, occasionally I would be in my office here in Baltimore and he would summon me to his office on St. Paul Street because he had someone who needed to be operated on, and he wanted me to go over the patient with him. So he truly mentored me through the process. And at the same time, he said, "You've got to become a member of the American Academy for Cerebral Palsy." And he was very insistent that it be called the American Academy for Cerebral Palsy and not the American Academy of Cerebral Palsy. But anyhow, he got me involved with the Academy, and that led to my getting active in the Academy. A year before I went to Elizabethtown, my wife and I lost our third child due to prematurity. And through the years, I became convinced that had that child survived, we certainly would have had a child with significant developmental disabilities. And so that has allowed me, I believe, either consciously or subconsciously, to associate with the families of these children and understand many of the issues that they have. And so this is perhaps why when people ask me when I'm going to retire, I say I don't know what that word means, and I'm still at it.
In my experience, the family is almost more important than the child. And the family was one of my most rewarding things at Kennedy Krieger. It was very rewarding to see a family come in with an infant or a young child, have no idea what the problem was, no idea what to do about it, and gradually over the next 2 or 3 years we see the child become a member of the family becomes more comfortable with everything, the siblings are more comfortable, and it's just very, very rewarding. One family comes to my mind. They had a daughter with physical disabilities, but academically very, very good. And this mother was absolutely convinced that her child should go to school be mainstream. And at that time, children just were not mainstream. And she worked and worked and worked, and I can remember going to the school with her, and the occupational therapist going to the school with her and getting everything settled so that maybe they would try her at school. Finally, they tried her at school, and she did really well, and she was mainstreamed all through high school, and is now a college graduate with an excellent, excellent job. And Mother just worked for everything. I think the affiliation with Hopkins just added so much to the things available for the child, all the different assessments, all the people involved, being at top of research for things going on. It just opened up the world for children and their family and their life to be associated with such an outstanding institution, which had such interest in the children with developmental disabilities. I became interested in physical therapy, babysitting for a family with a physically challenged child, and I wanted to go into physical therapy. And I did, and I had my training at Children's Hospital in Boston. But in the 50s, the main thing was polio, and I had a lot of training in polio. And then towards the end, I found this nice little cerebral palsy group of children, and they're just so interesting. It's just, there are no two children alike, and it's such a challenge to help them. And I just was so interested in that, and it just was even more so once we came to an affiliation with Hopkins. It was just so much more available and so much more knowledge to gain.
It was the ideal situation because we would see the patients in the clinic. We would outline a course of treatment with Susan and her staff. We're the occupational therapy staff, or the assistive technology people. We would then go through the tunnel to the Children's Center, where we would do the surgery in the Hopkins operating rooms. Post-operatively, the therapist could come over if there were any questions about anything. And then, for many of the patients, would come back through the tunnel to be admitted on the post-orthopedic floor at Kennedy for their intensive physical therapy. And it was just the best of all worlds for those patients to benefit from having the proximity of the expertise of the Hopkins medical staff working with us.
I think it was a very important transition when the Institute started seeing patients over age 21. There were very few services for children after they reached 21. School was out, there was just nothing. And the patients at the Institute, many of them we'd followed since infancy, were just getting older as time went on. And I think it was just a wonderful thing when Kennedy decided to expand their services and started seeing adults with developmental disabilities.
Our population has really grown in the adult field, and there's been a gradual increase. If you walk into the waiting area on the 4th floor of the 801 building at Kennedy Krieger Institute in East Baltimore, when you walk into that setting, I'm overwhelmed when I look out there and I see the number of adults in their 50s and their 60s waiting to be registered and seen. There are significant numbers of adults now who are coming in for physical therapy and occupational therapy, not necessarily to see the orthopedic doctors, but for many of the ancillary services that we provide.
And I think that that's true. Even though adults were being treated in other places, they were being treated for a specific thing, like orthopedic surgery or something, but not a holistic approach.
As part of my evaluation of the patients when they come into my clinic, the orthopedic clinic, in my intake history for each patient, particularly the teenagers and the adults, part of that is to ask them what kind of a social life they have, to see if there's anything that Kennedy Krieger disciplines in the various fields, any guidance that they can provide them with socializing in the community. And we have, I would say, probably in the field of social work, we have our behavior therapists and other disciplines at Kennedy Krieger that can help to direct some of these children who have some of these needs and interests or that they want to pursue to be headed in the right direction.
Yes, social work provides a number of groups, especially for teenagers and young adults, where they can discuss their needs and get help in joining or finding out about social programs in the area.
There is currently a family support group that has been put together that meets a lot of the social needs of these youngsters. There is a group called Kinetic Connections, or Cerebral Palsy Kinetic Connections. It's a group of parents, patients, many of whom are adults with cerebral palsy, who have developed a whole calendar of social events for them to socialize and meet each other, share their interests, discuss their needs that aren't being met, and what have you. The major contribution of the Kennedy Krieger Institute to the field in the research realm is the growth and development of the department or the section of neurogenetics. And that I think that there are a number of patients that we are now seeing who it was assumed that they had problems due to their prematurity or due to the lack of oxygen, what we call ischemic hypoxic encephalopathy around the time of term. But that many of these patients where it was assumed that that was a problem may have some underlying neurogenetic disorder that they're now identifying.